So here we go. First things first, anticipate and deal with factors that can derail treatment, rating scales. We're going to talk very specifically about the use of rating scales later. We might get to that this afternoon, if not in the next class. But one thing I want to say about rating scales is I know through a lot of my career I didn't use rating scales, and because I don't know, maybe it was just silly thinking on my part, but it seemed kind of artificial, or it just seemed like it might interfere with kind of the connection I had with my patients and that sort of thing. I'm going to make a compelling case for using rating scales for certain disorders when we get to the particulars. But in this one big study that was done called the STAR-D program, they asked people who were in the study, and had more than 4,000 patients, just how they felt about the use of rating scales, and overwhelmingly people thought it was great. And the reason it mainly was because they felt like they were being taken very seriously. That with each session there would be a review of how are you doing specifically. So rating scales can be very helpful. Okay, now skip over that. The next thing is data provided by significant others. This is very important for several reasons, and the practice guidelines from the American Psychiatric Association now strongly recommend that this be done in general with psychiatric patients, but especially people with mood disorders. Part of this has to do with getting the history. Now, let me tell you something, this is not uncommon. These are people who have bipolar II disorder. And we're going to see that bipolar II sometimes is challenging to diagnose because people don't come in for treatment for hypomanias. You know, if somebody's feeling great, they don't come in and say, "Oh, please help me, I'm feeling too good." You know, they come in with depressions, and if you ask the person the standard questions to see if they've had a history of hypomanic episodes, a lot of times they'll say, "No, that's never happened." But here's what you'll see if you start bringing a significant other, spouse or partner, and of course obviously parents with kids, but into the interview. Let's say we got this guy, Mr. Smith, who's got major depression, okay? And so you decide to have a half an hour of one of the early sessions, maybe the first session, have his wife come in and say, I'd like to ask you a question, Mr. Smith. Have you ever had a time that for several days you had a lot of energy, you felt really upbeat, and also that you probably didn't need to sleep very much, but you weren't tired during the day? Okay, that's classic questions to try to get a history of hypomania. And he goes, "No, that's never happened for me." But his wife comes in and says, "Now hang on just a minute here, wait just a minute. That's not exactly true. Honey, don't you remember, like sometimes a couple of times a year, you know, your woodworking project out in the garage, you'll just really get involved with it, and you'll be up to like 2 or 3 in the morning. I'll come out and I'll say, 'Come on, you need to go to bed.' No, I'll be there in a few minutes." And the next day, you may have only slept like 4 hours or so, but you're just, you know, really upbeat. He goes, "Well, yeah, that happened. That does happen. But I just really get involved in my project." Well, guess what? That's hypomania. Okay, especially decreased need for sleep, no fatigue during the daytime. Now, this guy is not trying to be dishonest at all, but he doesn't understand. He's looking at it from a different perspective. And people who have depression are notoriously poor historians. Okay, they can't remember stuff. It's not their fault, but it's just the nature of cognition during depression, to see things in concrete, black and white kinds of ways, and not be able to have perspective and that sort of thing. So getting the history is very, very important. The other thing is to engage the family, or at least the significant other, in developing a plan for relapse prevention. And it's true for many psychiatric disorders that there are going to be reoccurrences. Now, let's take an example. Bipolar disorder, 100% recurrence, okay? That's the nature of the disorder. Unipolar depression, 80% will have recurrent episodes. What you want to do is to have the husband and the wife, or it could be a partner, but let's say that the man is depressed, and say, what I want you to do is I want each one of you to independently, here in my office, take 15 minutes or so, or go out in the waiting room, take a piece of paper, and I want you to write down what you noticed were changes in your behavior prior to this depression. And I'm not talking about a day or two ahead of time. You can go back several weeks or a couple of months before that. And actually, I think in my next class, I'll bring you a little list of things to address, okay? But we're not just looking at mood changes, but we're looking at things like sleep patterns, appetite, the amount of engagement in normal life activities. Lots of times people, long before they say, I really feel depressed, they just start withdrawing from things, they disengage from life. Changes in sexual behavior, changes in spending. People that get manicky sometimes will kind of get revved up and start spending more money. Things like that, changes in their work habits, and so on and so forth. So it's not just a general question of when did you notice your husband getting depressed, but it's try to spot early behavioral changes, because it turns out that for each individual person, oftentimes when they have a next episode, you'll get the exact same kinds of early manifestations of the reoccurrence. And so what you want to do is to develop a very good early warning symptom list. And so then they do it independently, because people don't see things eye to eye. They're going to be different perspectives. And then you bring the two back together and you say, okay, what I want to do now is have us share notes and both mutually agree upon which of these symptoms probably was an early sign of your mania or depression or whatever, or psychotic symptoms. Okay, and then you go through that and come to some agreement, and then say, now we've got to have a partnership here to avoid reoccurrence. And cross your fingers, this may not reoccur. If you have depression, it may not reoccur. If you have bipolar, it's going to. Hopefully, the treatment can prevent recurrences. But we've got to get really good at this. And oftentimes, it's the partner who really notices changes before the person who has the disorder. Not always, but oftentimes. And so we've agreed upon, okay, these 5 things here were probably, signs of the depression beginning to develop. So what I want to do right now is I want to have us do a relapse drill. And talk to the wife and say, now, Ms. Smith, what I want you to do, and I'll help you here, is we're going to come up with a way for you to come and tell your husband that you're noticing the warning signs. And a lot of times, when people have had a spouse or partner go through a horrible psychosis or made a suicide attempt or something, they start seeing it come on again, they freak out. And who wouldn't? But when they approach them and go, oh my God, not this again, that kind of comment oftentimes is not terribly supportive. So you want to have them go back and forth and come up with maybe just a short phrase. You may even write it down on an index card, but it might be something like, honey, as we promised each other, I would come to you if I noticed any of these symptoms starting again, and you had given me permission to do that. That's what you're trying to do here in this couple session. And I'm noticing that you're sleeping in a lot more. You seem to be a lot more tired. I think it's absolutely essential now to go see your therapist. Maybe the person's been out of therapy, or they stopped taking their medicine, or something like that. And then have her practice that with a guy and really tailor it so it doesn't sound like it's being judgmental, and ask the guy, now, do you feel defensive? Having her say that. And just practice, okay? Don't send this is not a homework assignment. This is do a little role playing here, doing it 2 or 3 times, say, is that feeling comfortable for you to say this to him? Yeah, it's okay. Because this can really make a difference, especially with these more severe mental disorders, is to try to nip them in the bud. And I don't know if those of you that may have been practicing for a long time know this. People have recurrent depressions. They've had like a really bad depression, and then 5 years later they start having another one. And they wait 4 or 5 months before they come back in for treatment. And, I would say in a very gentle kind of way, basically, how come you didn't come in earlier? But, I've heard it again and again and again. Well, I thought this time I'd beat it, or maybe it'd go away or something like that. And we've had to just really get the point across that if this starts flaring up again, then we need to jump on it, okay, because we can prevent catastrophes. Here are two studies that are very telling. These are from the National Institute of Mental Health. And here, the patient is coming in with major depression. Now, a huge question clinically is, okay, they have major depression, but is it bipolar depression or is it unipolar depression? Because that's not just an academic question. If you don't treat it right, things can go from bad to worse quickly. Okay, so what they did is they had the patient was interviewed twice, one with just the patient and a clinician. The other was with the patient, a clinician, and their significant other. Okay, so it says individual interviews missed 60% of those identified with family interview. So those people that turned out to have bipolar disorder, 60% of those were misdiagnosed as unipolar disorder when they didn't have the history from the partner. That's a big deal. Okay? Now this will blow you away. NIMH again. These are people that you know they had mania because they were in the hospital for it, for God's sakes. And they followed up 5 years later, contacted them. 60% forgot or denied that they had ever had a manic episode. Does that blow your mind? Think you'd remember being in the hospital for 2 weeks with a manic episode? Okay. Again, I don't think it's a matter of people trying to lie about it. Now, Fred Goodwin used to be the head of NIMH. He's probably the preeminent researcher on bipolar disorder. And he said that when he started doing two things, one is life charting, which I'll show you when we get to bipolar, and interviewing a partner, that his diagnostic hit rate was at least 50% more accurate. And when you're talking about disorder that can go really down the toilet soon if you don't jump on it, okay, this is a big deal. Okay, it really is. All right. Many of us are going to be working with our colleagues in managed care, primary care medical settings. And it says here, this was a particular study, active involvement in decision making. And you know, things are beginning to turn, but there's still this notion about the passive patient and the sort of the omnipotent doctor, you know, who says, okay, trust me, I'm a doctor, you know, here, take this medicine and, you know, call me if it doesn't work or something like that. And what they found was, if they really stopped and asked patients, say, this is my recommendation, but I want to know how you feel about it. What are your opinions? What do you know about antidepressants, or, you know, whatever the drug was that they were using? Look at this, 62% fewer dropout rates when they would have a 5-minute discussion, just simply asking the person, I want to know your opinion about this. Do you think that should inform practice? You bet it should. Okay? All right. Now, asking about preferences and concerns. So let's take a look at something. Let's, maybe today, if not, then our next class we're going to look at those particular symptoms that would suggest a particular class of drug as a starting point for treatment. Now let's say that all things are pointing in the direction of using an SSRI. You got several options here, okay? And I'm going to try to convince you that just picking a drug out of the thin air is not the way to go. You want to look at the history and certain clinical features to make the decision. And so then you say, but let's talk about this, and I want to know what you know about antidepressants. Do you have any friends, relatives who've, you know, been treated for depression? Tell me everything you know. Practically everybody in the United States has heard these ads on TV about antidepressants, all of them saying and can cause increased suicidal behavior. You know, we'll talk about that later as well. So somebody says, well, actually, I know a lot of people take these medicines, but yeah, I read some stuff about it can make you commit suicide or something. You know, I mean, it's kind of scary. You think that matters? Yeah, you better believe it. And so then you talk about that, okay? Or you look at their pre-existing expectations. Somebody says, you know, actually, my best friend, she took Zoloft, and man, oh man, it really helped her. I mean, she was very depressed, and in a few months she was back on her feet. Guess what? That's exactly the drug I was thinking about. I mean, maybe you don't make it that obvious, but there's a positive expectation set, okay? And if your choice is between Paxil and Zoloft and Prozac, all other things being equal, somebody's got positive expectations, say, well, there's a couple of drugs in that class, but hey, look, let's go with Zoloft. How would that be for you? Or somebody said, oh God, one of my buddies took Effexor, and man, oh man, he got sick and diarrhea and all that kind of stuff. Okay, well look, for sure, let's stay away from that drug, and let's see if we can find something else that's probably less likely to have those symptoms. You look at the studies, you look at treatment guidelines, they never talk about this stuff. But I mean, maybe I'm just going on and on about this, but these are the kind of things that will make it or break it. You know, these what seem like obvious discussions where you really, really take the patient's feelings into consideration.